10.1 Analgesics and Musculoskeletal Introduction. Learning objectives. Identify the classifications and actions of analgesics. Identify the classifications and actions of musculoskeletal system drugs. Give examples of when, how, and to whom analgesics and musculoskeletal system drugs may be administered. Identify the side effects and special considerations associated with administering analgesics. Identify the side effects and special considerations associated with administering musculoskeletal system drugs. Identify the considerations and implications of using analgesics across the lifespan. Identify the considerations and implications of using musculoskeletal system medications across the lifespan. Apply evidence-based concepts when using the nursing process. Identify nursing responsibilities related to health teaching and health promotion. Complaints of pain are one of the most common reasons individuals seek medical care. The pain signal indicates that something in the body is not quite right. Whether it be a headache, a broken bone, labor pain, chest pain, or other condition, pain assessment and management are a part of nurses' daily work. It is essential for nurses to understand the physiology of pain and the pharmacological and non-pharmacological treatment methods available to effectively manage pain. 10.2 Basic concepts of analgesics and the musculoskeletal system. Before we discuss medications used to treat pain and musculoskeletal conditions, let's review the physiology of pain, as well as the anatomy and physiology of the musculoskeletal system. Review of the physiology of pain. Knowledge about the transmission and the processing of pain has greatly expanded in recent years due to a multidisciplinary approach. Although pain is considered something to be avoided, pain impulses are necessary for maintaining the integrity of our bodies and survival. Interactions between the nervous and immune systems are closely linked through cellular interactions in processing and transmitting pain sensation. However, prolonged or chronic pain can cause secondary symptoms, such as anxiety and depression, and can decrease an individual's overall quality of life. The transmission of pain is linked to nociceptors, specialized sensory neurons in the central nervous system that respond to painful stimuli. Nociceptors respond to harmful or potential tissue-damaging stimuli and transmit stimuli from the skin, muscles, joints, and viscera. The most nociceptor-rich tissue is the skin, which contains several different types of nociceptors. Nociceptors are further divided according to the type of stimuli they respond to. Nociceptor activation is determined by the pain stimulus and depends on the site of generation and mode of activation. The site of the stimulus is important because it can influence the intensity of the nociceptor response. An interesting example is corneal nociceptors, which are activated by weaker stimuli than skin nociceptors. The nature of the stimulus is also important. Stimuli brought about by cutting or crushing, for example, activate most skin nociceptors but do not activate nociceptor in the joints, muscles, or viscera, which instead quickly respond to other types of mechanical forces, such as rotation and distension. In addition to cutting and crushing injuries, harmful stimuli that are able to activate nociceptors in the skin also include chemical, thermal, and mechanical damage. A property of nociceptors is their ability to cause sensitization, a process that reduces the threshold of activation and an increased response rate to stimulation. Sensitization typically results from tissue injury and inflammation and can result in chronic pain. The pain sensation transmitted by neurons in the central nervous system is influenced by the immune system through the release of molecular mediators. These substances activate pain receptors, increase the sensitivity of pain receptors, and stimulate the release of inflammatory substances called prostaglandins. For a person to feel pain, the signal from the nociceptors in peripheral tissues must be transmitted to the spinal cord and then to the hypothalamus and cerebral cortex of the brain. The signal is transmitted to the brain by two types of nerve cells. The dorsal horn of the spinal cord is the relay station for information from these fibers. In the brain, the thalamus is the relay station for incoming sensory stimuli, including pain. From the thalamus, the pain messages are relayed to the cerebral cortex where they are 6-7 perceived. See Figure 10.1 for an illustration of how the pain signal is transmitted from peripheral tissues to the spinal cord and then to the brain. Figure 10.1 Transmission of pain from peripheral tissues to the brain. 6. Franson G. and Pennington S. Abrams's clinical drug, Rationales for Nursing Practice, pp. 305, 310, 952-953, 959-960, Wolters Kluwer, 7, Sketch-colored final.png by Bettina Guabelli, is licensed under CC by SA4. Endogenous pain relief. The CNS has an endogenous system for relieving pain. The CNS can suppress pain signals from the peripheral nerves by using endogenous opioid peptides that interact with opioid receptors to inhibit perception and transmission of pain signals. These endogenous opioid peptides are endorphins, enkephalins, and dynorphins. Visit the YouTube video below for more information about how pain relievers work. How do pain relievers work? By George Zidon. Review of Anatomy and Physiology of the Musculoskeletal System. In the musculoskeletal system, the muscular and skeletal systems work together to support and move the body. The bones of the skeletal system serve to protect the body's organs, support the weight of the body, and give the body shape. The muscles of the muscular system attach to these bones. See Figure 10.2 for and pulling on them to allow for movement of the body. Illustration of the musculoskeletal system. Major muscles of the body. Right side superficial, left side deep. Figure 10.2 Musculoskeletal system. Muscles. The body contains three types of muscle tissue. Skeletal muscle, smooth. Skeletal muscle is voluntary and striated. These are the muscles that attach to bones and control conscious movement. Smooth muscle is involuntary and non-striated. It is found in the hollow organs of the body such as the stomach, intestines, and around blood vessels. Cardiac muscle is involuntary and striated. It is found only in the heart and is specialized to help pump blood throughout the body. When a muscle fiber receives a signal from the nervous system, myosin filaments are stimulated, pulling actin filaments closer together. This shortens sarcomeres within a fiber, causing it to contract. 10.3 Acute pain, chronic pain, and musculoskeletal disorders. Acute pain, chronic pain, and common musculoskeletal disorders are reviewed in this section. Acute pain. Acute pain usually comes on suddenly and is caused by something specific like an injury or surgery. It lasts less than 3 months and usually goes away when there is no longer an underlying cause for the pain. Examples of acute pain include the following: surgery, broken bones, dental work, burns or cuts, labor and childbirth. Chronic pain. Chronic pain is pain that is ongoing and usually lasts longer than 6 months. This type of pain can continue even after the injury or illness that caused it has healed or gone away. Pain signals remain active in the nervous system for weeks, months, or years. Some people suffer chronic pain even when there is no past injury or apparent body damage. Chronic pain is linked to many conditions, including these conditions: headache, arthritis, cancer, nerve pain, back pain, fibromyalgia pain. People who have chronic pain can have physical effects that are stressful on the body. These include tense muscles, limited ability to move around, a lack of energy, and appetite changes. Emotional effects of chronic pain include depression, anger, anxiety, and fear of re-injury. Such a fear might limit a person's ability to return to their regular work or leisure activities. Fibromyalgia. Fibromyalgia is a condition that causes pain all over the body, sleep problems, fatigue, and often emotional and mental distress. People with fibromyalgia may be more sensitive to pain than people without fibromyalgia. This is called abnormal pain perception processing. Fibromyalgia affects about 4 million U.S. adults, about 2% of the adult population. The cause of fibromyalgia is not known, but it can be effectively 3% treated and managed. The most common symptoms of fibromyalgia are the following: pain and stiffness all over the body, fatigue and tiredness, depression and anxiety, sleep problems, problems with thinking, memory, and concentration, headaches including migraines. Other symptoms may present including these symptoms: tingling or numbness in hands and feet, pain in the face or jaw, including disorders of the jaw known as temporomandibular joint syndrome, digestive problems such as abdominal pain, bloating, constipation, and even irritable bowel syndrome. These are the known risk factors. Age. Fibromyalgia can affect people of all ages including children, however, most people are diagnosed during middle age. Lupus or rheumatoid arthritis. Clients diagnosed with lupus or rheumatoid arthritis are more likely to develop fibromyalgia. Other factors that have been weakly associated with onset of fibromyalgia are as follows. Sex. Women are twice as likely to have fibromyalgia as men. Stressful or traumatic events, such as car accidents or post-traumatic stress disorder. Repetitive injuries. Injury from repetitive stress on a joint, such as frequent knee bending. Illness. Family history. Obesity. Doctors usually diagnose fibromyalgia using the client's history, physical examination, x-rays, and blood work. Gout. Gout is a common form of inflammatory arthritis that is very painful. It usually affects one joint at a time. There are times when symptoms get worse, known as flares, and times when there are no symptoms, known as remission. Repeated bouts of gout can lead to gouty arthritis, a worsening form of arthritis. There is no cure for gout, but you can effectively treat and manage the condition with medication and self-management strategies. Gout flares start suddenly and can last days or weeks. These flares are followed by long periods of remission without symptoms before another flare begins. Along with the big toe, joints commonly affected are the lesser toe joints, the ankle, and the knee. Symptoms in the affected joint may include the following: pain, usually intense, swelling, redness, heat. Gout is caused by a condition known as hyperuricemia, where there is too much uric acid in the body. The body makes uric acid when it breaks down purines, which are found in your body and the foods you eat. When there is too much uric acid in the body, uric acid crystals can build up in joints, fluids, and tissues within the body. Hyperuricemia does not always cause gout, and hyperuricemia without gout symptoms does not need to be treated. The following make it more likely that you will develop hyperuricemia, which causes gout. Being male, being obese, having certain health conditions can also increase your chances of developing hyperuricemia. These conditions include the following: congestive heart failure, hypertension, insulin resistance, metabolic syndrome, diabetes, poor kidney function. Additional factors may increase your chances of developing hyperuricemia. Using certain medications, such as diuretics, drinking alcohol. The risk of gout is greater as alcohol intake increases. Eating or drinking food and drinks high in fructose. Having a diet high in purines, which the body breaks down into uric acid. Purine-rich foods include red meat, organ meat, and some kinds of seafood, such as anchovies, sardines, mussels, scallops, trout, and tuna. A medical doctor diagnoses gout by assessing your symptoms and the results of your physical examination, x-rays, and lab tests. Gout can be diagnosed only during a flare, when a joint is hot, swollen, and painful, and when a lab test finds uric acid crystals in the affected joint. Muscle spasm. Spasms of skeletal muscles are most common and are often due to overuse and muscle fatigue, dehydration, and electrolyte abnormalities. The spasm occurs abruptly, is painful, and is usually short-lived. It may be relieved by gently stretching the muscle. Diseases such as multiple sclerosis can also cause chronic muscle spasms. Multiple sclerosis. Multiple sclerosis involves an immune-mediated disease process, in which an abnormal response of the body's immune system is directed against the central nervous system. The CNS is made up of the brain, spinal cord, and optic nerves. Within the CNS, the immune system causes inflammation that damages myelin, as well as the nerve fibers themselves and the specialized cells that make myelin. When myelin or nerve fibers are damaged or destroyed in MS, messages within the CNS are altered or stopped completely. Damage to areas of the CNS may produce a variety of neurological symptoms that will vary among people with MS in type and severity. The damaged areas develop scar tissue that gives the disease its name, multiple areas of scarring or multiple sclerosis. The cause of MS is not known, but it is believed to involve genetic susceptibility, abnormalities in the immune system, and environmental factors that combine to make MS symptoms variable and unpredictable. No two people have exactly the same symptoms, and each person's symptoms can change or fluctuate over time. One person might experience only one or two of the possible symptoms, while another person might experience several symptoms of the disease. These are some symptoms of MS: fatigue, numbness or tingling, weakness, dizziness or vertigo, walking difficulties, muscle spasticity, blurred vision, At this time, there are no symptoms, physical findings, or laboratory tests that can, by themselves, determine if a person has MS. Several strategies are used to determine if a person meets the long-established criteria for a diagnosis of MS, and to rule out other possible causes of whatever symptoms they are experiencing. These strategies include a careful medical history, a neurologic exam, and various tests, including magnetic resonance imaging, spinal fluid analysis, and blood tests. Myasthenia gravis. Myasthenia gravis is an autoimmune disease that occurs when the immune system attacks the body's own tissues. In MG, the attack interrupts the connection between nerve and muscle, called the neuromuscular junction. Myasthenia gravis is characterized by autoantibodies against the acetylcholine receptor, or against a receptor-associated protein called muscle-specific tyrosine kinase. You can read more details about acetylcholine receptors in the autonomic nervous system chapter. MG causes weakness in muscles that control the eyes, face, neck, and limbs. Symptoms include partial paralysis of eye movements, double vision, and droopy eyelids, as well as weakness and fatigue in the neck and jaw, and problems chewing, swallowing, and holding up the head. MG is treatable with drugs that suppress the immune system or boost the signals between nerves 9 and muscles. The group of drugs used to control MG is called acetylcholinesterase inhibitors. They inhibit the action of the enzyme acetylcholinesterase, so that more acetylcholine is available to activate cholinergic receptors and promote muscle contraction. ACH inhibitors are classified as parasympathomimetic. Pyridostigmine is an example of an ACH inhibitor. Overdosing with ACH inhibitors can cause a complication called cholinergic crisis, which is an acute exacerbation of symptoms. A cholinergic crisis usually occurs 30 to 60 minutes after taking cholinergic medication with severe muscle weakness that can lead to respiratory paralysis and death. 10.4. Applying the nursing process to pain management. Now that we have reviewed basic concepts related to pain and several disorders requiring analgesic or musculoskeletal medication, let's consider the nursing process and how it applies to administering these medications. Assessment. Asking a patient to rate the severity of their pain on a scale from 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, is a common question used to screen patients for pain. However, according to the Joint Commission requirements, this question can be used to initially screen a patient for pain, but a comprehensive pain assessment is required for adequate pain management. Nurses perform comprehensive pain assessments before and after administering analgesics. Many mnemonics are used to guide comprehensive pain assessment. See Figure 10.4 for common nursing mnemonics for comprehensive pain assessment. Figure 10.4 Mnemonics for pain assessment. To adequately manage a client's pain, it is important to also assess potential barriers that may contribute to inaccurate reports of the severity of pain by individuals. Optimal pain management can be achieved by gathering subjective and objective data to accurately measure the severity of an individual's pain. A person's health can be negatively impacted if they underrate or overrate their pain level. Underrated severe pain can interfere with an individual's ability to complete activities of daily life and can contribute to anorexia, insomnia, and feelings of depression and anxiety. Additionally, some clients are not able to adequately communicate their pain. For example, for older adults with cognitive impairment, caregivers play an important role in documenting and communicating pain assessments to nurses and healthcare providers to ensure adequate treatment of pain. Visual pain rating scales. Visual pain scales are commonly used as tools for assessing pain, especially with children and adults who have difficulty using the numerical pain rating 4 scale. See Figure 10.5 for the FACES pain rating scale. To apply this scale, use the following evidence-based instructions. Explain to the client that each face represents a person who has no pain, some, or a lot of pain. Face 0 doesn't hurt at all. Face 2 hurts just a little. Face 4 hurts a little more. Face 6 hurts even more. Face 8 hurts a whole lot. Face 10 hurts as much as you can imagine, although you don't have to be crying to have this worst pain. Ask the person to choose the face that best represents the pain they are feeling. Figure 10.5 Wong-Baker FACES pain rating scale. Used with permission from http://www.wongbakerfaces.org. Additional baseline information to collect prior to administration of analgesic or musculoskeletal medication includes obtaining a history of allergies or previous adverse response to medications. Additionally, nurses ask clients to describe their preferred acceptable pain level while also considering the potential side effects of analgesics. Read additional information about pain assessment and pain scales in the Comfort chapter of Open RN Nursing Fundamentals. Implementation. As with all medications, nurses check the rights of medication administration and consider the best route of administration for this client at this particular time. For example, if the client is nauseated and vomiting, then an oral route may not be effective. When administering opioids, the nurse considers if the prescribed medication is appropriate for the client's current level of pain. If there are concerns about appropriateness of the medication based on the client's current status, the prescribing provider should be notified. See Table 10.4 for a list of common opioid medications used to treat moderate to severe pain. Notice that many opioids are combined with acetaminophen, so the maximum daily dosage of acetaminophen must be monitored. Table 10.4 Common opioid analgesics used to treat mild to severe pain. WHO ladder. A general rule of thumb when administering analgesics is pain control should be based on the pain level reported by the client, and the least invasive medication with the least side effects should be used to treat that level of pain. The WHO ladder was originally developed for a selection of analgesics for clients with cancer. It illustrates the concept that pain control should be based on the level indicated by the client. See Figure 10.6 for an image of the original WHO ladder. Figure 10.6 WHO pain ladder. This diagram below shows the stepwise approach to cancer pain management recommended by the World Health Organization. The original WHO ladder consisted of 3 steps. First step, mild pain, non-opioid analgesics, such as non-steroidal anti-inflammatory drugs or acetaminophen, are administered with or without adjuvants. Second step, moderate pain, weak opioids, hydrocodone, codeine, tramadol with or without non-opioid analgesics, are administered with or without adjuvants. Third step, severe and/or persistent pain, potent opioids are administered with or without non-opioid analgesics, and with or without adjuvants. Adjuvant refers to medications typically used for indications other than pain, but can be help in various painful conditions. Adjuvants include antidepressants, serotonin-norepinephrine reuptake inhibitors, anticonvulsants such as gabapentin and pregabalin, topical anesthetics such as a lidocaine patch, topical therapies such as capsaicin, corticosteroids, bisphosphonates, and 8 cannabinoids. The fundamental concept of the WHO ladder is that it is essential to thoroughly assess pain in each individual and then manage that pain by using appropriate medications. For clients receiving opioids, the optimum dosage for pain relief must be balanced with the side effects of the drug. Additionally, clients should receive health teaching about the uses and side effects of pain medications to avoid misuse without compromising their 9 benefits. The WHO ladder has undergone several modifications over the years and is currently used to manage other types of acute and chronic pain. A limitation of the original scale was the absence of non-pharmacological treatments in the pain management path. Consequently, a 4th step was added to the ladder. This 4th step includes numerous non-pharmacological procedures used for treating persistent pain, such as epidural analgesia, intrathecal administration of analgesic and local anesthetic drugs, neurosurgical TEN procedures, and nerve blocks. The updated WHO analgesic ladder focuses on the quality of life and extends the strategy to treat pain. For acute pain, the strongest analgesic is the initial therapy and later toned down, whereas for chronic pain, a stepwise approach from bottom to 11 top may be employed. For example, if a client reports acute pain rated as 2%, then it is appropriate to start at the lowest rung of the ladder and administer a prescribed NSAID. However, it may be clinically indicated to start at level 3 on the WHO ladder for clients who present with severe acute pain and administer a potent opioid like morphine. Managing side effects. In addition to administering analgesics, nurses anticipate side effects, adverse effects, and plan appropriate monitoring, as well as administering additional medication if needed. For example, an adverse effect of opioid analgesics is respiratory depression. After administering an opioid medication, The nurse plans to monitor the client's respiratory rate and pulse oximetry level. Other common side effects of opioids include constipation or nausea, so the nurse anticipates administering medications such as stool softeners or antiemetics. Health teaching and health promotion. Nurses teach clients, their family members, and caregivers about appropriate pain management, pain medications, and symptoms to report that may indicate side effects, adverse effects. Controlled substances like opioids also have special regulations regarding storage, auditing counts, and disposal or wasting of medication. See more information about controlled substances in the Legal Ethical chapter. Evaluation. Nurses evaluate and document the client's response to the administered analgesics based on the medication's onset and peak. With analgesic medications, the nurse typically evaluates the client for a decreased level of pain 30 minutes after IV administration and 60 minutes after oral medication. If the client's pain level is not acceptable at that time, the nurse investigates alternate pharmacological and non-pharmacological treatments, such as aromatherapy, repositioning, hot or cold treatments, and listening to music. Because the nurse is the client's advocate, the healthcare provider should be notified if the client's pain is not being adequately managed by the prescribed analgesics. 10.5 Analgesic and musculoskeletal medications. Analgesics used to treat pain are categorized as non-opioid, opioid, and adjuvant medications. Non-opioid medications include acetaminophen and non-steroidal anti-inflammatory drugs. There are several types of opioids, as listed in Table 10.4 in the previous Applying the Nursing Process to Pain Management section. Adjuvant analgesics are defined as drugs with a primary indication other than pain that have analgesic properties in some painful conditions. This group includes numerous drugs in diverse classes such as gabapentin, amitriptyline, or muscle relaxants. Each of these classes will be discussed in more detail, along with anti-gout medications and a brief overview of anesthetic medication. Analgesic and musculoskeletal medication classifications. Let's take a closer look at different classes of analgesics and musculoskeletal medications with specific administration considerations, therapeutic effects, side effects, adverse effects, and health teaching needed for each class of medications. Keep in mind that analgesic and musculoskeletal medications are available in many different forms, such as oral tablets, oral liquids, injections, inhalation, and transdermal patches. Some products contain more than one medication to synergistically enhance pain relief. 10.6 Non-opioid analgesics. Non-opioid analgesics include acetaminophen and non-steroidal anti-inflammatory drugs. Acetaminophen. Mechanism of action. Acetaminophen inhibits the synthesis of prostaglandins that may serve as mediators of pain and fever, primarily in the CNS. Indications. Acetaminophen is used to treat mild pain and fever, however, it does not have anti-inflammatory properties. Nursing considerations. Acetaminophen is safe for all ages and can be administered using various routes. Geriatric populations should not exceed 3,000 mg in 24 hours, and chronic alcoholics should not exceed 2,000 mg in 24 hours due to the risk for hepatotoxicity. Side effects. Adverse effects. Adverse effects include skin reddening, blisters, rash, and hepatotoxicity. Severe liver damage may occur if a client does the following: takes more than 4,000 mg of acetaminophen in 24 hours, takes with other drugs containing acetaminophen, consumes 3 or more alcoholic drinks every day while using this product. Some medications are combined with acetaminophen and are prescribed as needed, so the nurse must calculate the cumulative dose of acetaminophen. 2. Valorand A and Sanoski C.A. Davis's Drug Guide for Nurses. F.A. Davis Company. Over the previous 24-hour period, for example, Percocet 5, 325, contains a combination of oxycodone 5 mg and acetaminophen 325 mg, and could be ordered 1 to 2 tablets every 4 to 6 hours as needed for pain. If 2 tablets are truly administered every 4 hours over a 24-hour period, this would add up to 3,900 mg of acetaminophen, which would exceed the recommended guidelines for a geriatric client and could cause liver damage. If overdose occurs, the antidote is acetylcysteine. Health teaching and health promotion, medications should be taken as directed and the dosing schedule should be adhered to appropriately. Clients should not take the medication for greater than 10 days. Additionally, clients should avoid taking alcohol while using these medications. If a rash occurs, this should be reported to the healthcare provider, and the medication should be promptly stopped. Use of medications may interfere with blood glucose monitoring. If a fever lasts longer than 3 days or exceeds 39.50 C, this should be reported to the healthcare provider. Now let's take a closer look at the medication grid on acetaminophen in Table 10.6a. Medication grids are intended to assist students to learn key points about each medication. Because information about medication is constantly changing, nurses should always consult evidence-based resources to review current recommendations before administering specific medications. Basic information related to each class of medication is outlined below. Detailed information on a specific medication can be found for free at DailyMed. On the home page, enter the drug name in the search bar to read more about the medication. Prototype generic medications listed in the grids below are also linked to a DailyMed page. Table 10.6a Acetaminophen Medication Grid. A client is admitted to the hospital with acute liver failure due to acetaminophen toxicity. The client reveals they have had a cold for several days and have been taking over-the-counter cold medications and acetaminophen for a headache. They also mention that every night after work they drink a few beers. What health teaching about acetaminophen should be provided? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Non-steroidal anti-inflammatories. Non-steroidal anti-inflammatories have an analgesic effect, as well as antipyretic and anti-inflammatory actions. Some, such as aspirin, also have an antiplatelet effect. Aspirin and other NSAIDs relieve pain by inhibiting the biosynthesis of prostaglandin by different forms of the COX enzyme. COX-2 inhibitors are selective and only inhibit the COX-2 enzyme. As a result of the inhibition of COX-1 by an NSAID, there is decreased protection of the stomach lining and gastric irritation and bleeding may occur. This section will discuss the following NSAIDs: aspirin, ibuprofen, ketorolac and celecoxib. Aspirin. Mechanism of action. Aspirin produces analgesia and reduces inflammation and fever by inhibiting the production of prostaglandins. It also decreases platelet aggregation. Indications: aspirin is used for the treatment of mild pain and fever. Once-daily dosages are also used to reduce the risk of heart attack and stroke. Nursing considerations: aspirin is safe for adults and children older than 12 years of age. Side effects: adverse effects. Adverse effects include GI upset, GI bleed, and tinnitus. Boxed warning: children or teenagers should not take aspirin to treat chickenpox or flu-like symptoms because of the risk of Reye's syndrome. Reye's syndrome primarily occurs in children in conjunction with a viral illness. It can cause symptoms such as persistent vomiting, confusion, or loss of consciousness, and requires immediate medical attention. Allergy alert: aspirin may cause a severe allergic reaction, which may include the following: hives, facial swelling, shock, asthma, stomach bleeding. Warning: this product contains an NSAID, which may cause severe stomach bleeding. The chance for bleeding is higher if a client takes a higher dose or takes it for a longer time than directed, takes other drugs containing prescription or non-prescription NSAIDs, has had stomach ulcers or bleeding problems, takes a blood thinning or steroid drug, is age 60 or older, has 3 or more alcoholic drinks every day while using this product. Aspirin is contraindicated if the client has a bleeding disorder such as hemophilia or a recent history of bleeding in the stomach or intestine. Health teaching and health promotion: clients should avoid concurrent use of alcohol while taking medication to avoid gastric irritation. Additionally, they should report tinnitus, unusual bleeding, or fever lasting greater than 3 days to the healthcare provider. Now let's take a closer look at the medication grid on aspirin in Table 10.6 Billions. Table 10.6 Billions Aspirin Medication Grid. A client asks why aspirin is given to prevent a heart attack or stroke. What is the nurse's response? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Ibuprofen. Mechanism of action: ibuprofen inhibits prostaglandin synthesis. Indications: ibuprofen is used to treat mild to moderate pain and fever, inflammatory disorders including rheumatoid arthritis and osteoarthritis, and pain associated with dysmenorrhea. Nursing considerations: ibuprofen is safe for infants 6 months or older. It is especially important not to use ibuprofen during the last 3 months of pregnancy unless directed to do so by a doctor, because it may cause complications during delivery or in the unborn child. Side effects, adverse effects. Adverse effects include headache, GI bleed, constipation, dyspepsia, nausea, vomiting, Stevens-Johnson syndrome, and renal failure. Allergy alert: ibuprofen may cause a severe allergic reaction, especially in people allergic to aspirin. Symptoms may include the following: hives, facial swelling, asthma, shock, skin reddening, rash, blisters, stomach bleeding. Warning: this product contains a non-steroidal anti-inflammatory drug, which may cause severe stomach bleeding. The chance for bleeding is higher if the client is age 60 or older, has had stomach ulcers or bleeding problems, takes a blood thinning or steroid drug, takes other drugs containing prescription or non-prescription NSAIDs, has 3 or more alcoholic drinks every day while using this product, takes more or for a longer time than directed. Heart attack and stroke. Warning: all NSAIDs except aspirin increase the risk of heart attack, heart failure, and stroke. These can be fatal. The risk is higher if the client takes more than is directed or takes it for longer than directed. Boxed warning: ibuprofen is contraindicated for the treatment of perioperative pain after coronary artery bypass graft. Health teaching and health promotion: clients should consume the medication with a full glass of water and remain upright for 30 minutes following medication administration. They should avoid the use of alcohol while taking this medication. Clients should be advised to not take the medication for longer than 10 days. If the client notices rash, visual changes, tinnitus, weight gain, or influenza-like symptoms, these should be reported to the healthcare provider immediately. Now let's take a closer look at the medication grid on ibuprofen in Table 8.10.6c. Table 10.6c Ibuprofen Medication Grid. A client who is a chronic alcoholic asks if it is okay to take ibuprofen for knee pain. What is the nurse's best response? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Ketorolac. Ketorolac is an NSAID that is commonly used to treat breakthrough pain that occurs during the treatment of severe acute pain being treated with opioids. Mechanism of action: ketorolac inhibits prostaglandin synthesis. Indications: ketorolac is indicated for the short-term management of moderate to severe acute pain that requires analgesia at the opioid level. Nursing considerations: ketorolac is safe for adults. This dose should be reduced for clients ages 65 and over. Side effects: adverse effects. Adverse effects include drowsiness, headache, GI bleed, abnormal taste, dyspepsia, nausea, Stevens-Johnson syndrome, edema, and renal failure. Gastrointestinal risk: ketorolac tromethamine can cause peptic ulcers, gastrointestinal bleeding, and/or perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Therefore, ketorolac tromethamine is contraindicated in clients with active peptic ulcer disease, in clients with recent gastrointestinal bleeding or perforation, and in clients with a history of peptic ulcer disease or gastrointestinal bleeding. Elderly clients are at greater risk for serious gastrointestinal events, cardiovascular thrombotic events. Non-steroidal anti-inflammatory drugs cause an increased risk of serious cardiovascular thrombotic events, including myocardial infarction and stroke, which can be fatal. This risk may occur early in treatment and may increase with duration of use. Ketorolac tromethamine is contraindicated for clients who have recently received coronary artery bypass graft surgery. Renal risk: ketorolac tromethamine is contraindicated in clients with advanced renal impairment and in clients at risk for renal failure due to volume depletion. Risk of bleeding: ketorolac tromethamine inhibits platelet function and is therefore contraindicated in clients with suspected or confirmed cerebrovascular bleeding, hemorrhagic diathesis, incomplete hemostasis, and a high risk of bleeding. Ketorolac tromethamine is contraindicated as a prophylactic analgesic before any major surgery. Hypersensitivity reactions: hypersensitivity reactions ranging from bronchospasm to anaphylactic shock have occurred. and appropriate counteractive measures must be available when administering the first dose of ketorolac. Ketorolac tromethamine is contraindicated in clients with previously demonstrated hypersensitivity to ketorolac tromethamine or who have had allergic manifestations to aspirin or other non-steroidal anti-inflammatory drugs. Health teaching and health promotion. The use of ketorolac may cause dizziness of drowsiness. Clients should also avoid alcohol or other aspirin-containing products unless directed by their healthcare provider. If the client notices rash, visual changes, tinnitus, weight gain, or influenza-like symptoms, these should be reported to the healthcare provider immediately. Now let's take a closer look at the medication grid on ketorolac in Table 10.6d. 10. Table 10.6d Ketorolac Medication Grid. Ketorolac 4 was administered to a client for severe pain due to a back injury. When should the effectiveness of the medication be evaluated? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Celecoxib. Celecoxib is a COX-2 inhibitor. Mechanism of action: celecoxib specifically inhibits the enzyme COX-2 that is required for the synthesis of prostaglandins. Indications: celecoxib is used to treat the pain associated with osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. It also relieves the pain associated with dysmenorrhea. Nursing considerations: celecoxib is safe for children 2 years or older. There is a boxed warning for required dosage adjustment for clients with hepatic impairment. Side effects: adverse effects include hypertension, peripheral edema, increased liver enzymes, abdominal pain, dyspepsia, gastroesophageal reflux disease, vomiting, and diarrhea. Boxed warnings: there are boxed warnings for increased risk of cardiovascular events and gastrointestinal bleeding, ulceration, and perforation. See more information about each condition below. Cardiovascular thrombotic events. Non-steroidal anti-inflammatory drugs cause an increased risk of serious cardiovascular thrombotic events, including myocardial infarction and stroke, which can be fatal. This risk may occur early in the treatment and may increase with duration of use. Celecoxib capsules are contraindicated in clients who have recently received coronary artery bypass graft surgery. Gastrointestinal bleeding, ulceration, and perforation. NSAIDs cause an increased risk of serious gastrointestinal adverse events, including bleeding, ulceration, and perforation of the stomach or intestines, which can be fatal. These events can occur at any time during use and without warning symptoms. Elderly clients and clients with a prior history of peptic ulcer disease and/or GI bleeding are at greater risk for serious events. Health teaching and health promotion. Clients should take medication as directed and use the lowest effective dose for the shortest period of time. If signs of GI toxicity occur, these should be reported immediately to the Health 11 care provider. Now let's take a closer look at the medication grid on celecoxib in Table 12.10.6e. Table 10.6e Celecoxib Medication Grid. Critical Thinking Activity 10.6e. A client has been prescribed celecoxib for their arthritic pain. What patient teaching does the nurse plan to provide? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Test your knowledge with this NCLEX Next Generation Style Bowtie question. Test your knowledge. Acetaminophen. 10.7 Opioid analgesics and antagonists. Opioid analgesics are prescribed for moderate and severe pain. There are several types of opioids, as listed in Table 10.4 in the previous Applying the Nursing Process to Pain Management section. Before discussing morphine, the prototype opioid analgesic, and its antagonist naloxone, let's discuss the opioid epidemic in the United States, efforts to stop this epidemic, and the dangers of drug diversion. Understanding the opioid epidemic. The drug overdose epidemic continues to worsen in the United States. Overdose deaths remain a leading cause of injury-related death. In the United States, drug overdoses have claimed over 932,000 lives over the past 21 years. The majority of overdose deaths involve opioids. Deaths involving synthetic opioids have increased in recent years, especially one during the COVID-19 pandemic. The rise in opioid overdose deaths can be outlined in 3 distinct waves. 2. For a graphic representation of the waves of opioid deaths, see Figure 10.7. Figure 10.7. 3 waves of opioid overdose deaths. The first wave began with increased prescribing of opioids in the 1990s, with overdose deaths involving prescription opioids. The second wave began in 2010 with rapid increases in overdose deaths involving heroin. The third wave began in 2013, with significant increases in overdose deaths involving synthetic opioids, especially those involving illicitly manufactured fentanyl. CDC's educational campaigns. To save lives from drug overdose, the Centers for Disease Control and Prevention launched 4 education campaigns to reach young adults. The campaigns provide information that can save the lives and highlight actions the public can take to help prevent overdose. Specifically, the campaigns provide critical information about these topics: dangers of fentanyl, risks and consequences of mixing drugs, life-saving power of naloxone to reverse an opioid overdose, importance of reducing stigma to support treatment and recovery. Read more information about the CDC campaigns to stop overdose deaths. CDC guidelines for prescribing opioids for chronic pain. In addition to establishing educational campaigns to prevent opioid deaths, the CDC has also established new clinical practice guidelines regarding the prescription of opioids to ensure clients have access to safer, effective pain treatment, while also reducing the number of people who misuse or overdose from these drugs. The CDC's Clinical Practice Guidelines for Prescribing Opioids, United States 2022 was developed for the prescribing of opioid pain medication for clients 18 and older in primary care settings. Recommendations focus on the use of opioids in treating acute pain, subacute pain. This clinical practice guideline is intended to improve communication between clinicians and clients about the benefits and risks of pain treatments, including opioid therapy, improve the effectiveness and safety of pain treatment, mitigate pain, improve function and quality of life for clients with pain, and reduce risks associated with opioid pain therapy, including opioid 5 use disorder, overdose, and death. Nurses also play an important component in advocating for these outcomes. 4 key areas are covered in the CDC's Clinical Practice Guidelines for 6 prescribing opioids. 1. Determining whether or not to initiate opioids for pain. 2. Selecting opioids and determining opioid dosages. 3. Deciding duration of initial opioid prescription and conducting follow-up. 4. Assessing risk and addressing potential harms of opioid use. In addition, 5 guiding principles were identified. 1. Appropriate treatment of pain. 2. Flexibility to meet the care needs and clinical circumstances of each client. 3. A multimodal and multidisciplinary approach to pain management. 4. Avoiding misapplication of the clinical practice guideline beyond its intended use. 5. Vigilance in attending to health inequities and ensuring access to appropriate, affordable, diversified, coordinated, and effective non-pharmacologic and pharmacologic pain treatment for all persons. Improving the way opioids are prescribed through clinical practice guidelines can ensure clients have access to safer, more effective pain treatment, while also reducing the risk of opioid use disorder, overdose, and death. Drug diversion and impaired healthcare workers. Drug diversion is a potential threat to patient safety in every healthcare. 5. Centers for Disease Control and Prevention. Clinical Practice Guidelines for Prescribing Opioids, United States 2022. 6. Centers for Disease Control and Prevention. Clinical Practice Guidelines for Prescribing Opioids, United States 2022. Organization. Drug diversion involves the transfer of any legally prescribed controlled substance from the individual for whom it was prescribed to another person for illicit use. The most commonly diverted substances in healthcare facilities are opioids. Risks to clients from drug diversion include inadequate pain relief compounded by potentially unsafe care due to the healthcare worker's impaired performance. More information about drug diversion and substance use disorder in healthcare professionals is discussed in the Legal Foundations and National Guidelines for Safe Medication Administration section of the Legal Ethical Chapter. Opioid medication class. See Table 10.4 in the Nursing Process for Analgesics and Musculoskeletal Medications section of this chapter for a list of common opioid medications used to treat moderate to severe pain. As discussed in that section, morphine is at the top of the WHO ladder and is used to treat severe pain. It is also commonly used to treat cancer pain and for pain at end of life because there is no ceiling effect, meaning the higher the dose, the higher the level of analgesia. Morphine is also commonly used in patient-controlled analgesia. Other medications administered via PCA include hydromorphone or fentanyl. To receive the opioid using a PCA device, the patient pushes a button, which releases a specific dose but also has a lockout mechanism to prevent an overdose. Morphine. Morphine is an example of a potent opioid used to treat severe pain. Mechanism of action: morphine binds to opioid receptors in the CNS. And 8. The Joint Commission Division of Healthcare Improvement, Drug Diversion and Impaired Healthcare Workers. Quick Safety. 9. MC Question L, Voljoin DiMaggio K, Winton M, and Yeager J. Pharmacology, a patient-centered nursing process approach, pp. 268-270, 324, 332. Elsevier alters the perception of and response to painful stimuli while producing generalized CNS depression. Indications: morphine is indicated for the relief of moderate to severe acute and chronic pain and for pulmonary edema. Nursing considerations: morphine is safe for all ages. Use cautiously with clients with liver and renal impairment. Side effects: adverse effects. Adverse effects include respiratory depression, hypotension, lightheadedness, dizziness, sedation, constipation, nausea, vomiting, and sweating. Health teaching and health promotion. Clients should be advised regarding the risks associated with opioid analgesic use. Please see the outlined special considerations for usage below. Boxed warning. The risk of serious adverse reactions, including slowed or difficulty breathing and death, have been reported with the combined effects of morphine with other CNS depressants. Naloxone is used to reverse opioid overdose. There is also a risk of drug abuse and dependence with morphine. Special considerations. Respiratory depression. Respiratory depression is the primary risk of morphine sulfate. Respiratory depression occurs more frequently in elderly or debilitated clients and in those suffering from conditions accompanied by hypoxia, hypercapnia, or upper airway obstruction, for whom even moderate therapeutic doses may significantly decrease pulmonary ventilation. Use morphine with extreme caution in clients with chronic obstructive pulmonary disease or cor pulmonale, and in clients having a substantially decreased respiratory reserve, hypoxia, hypercapnia, or pre-existing respiratory depression. In such clients, even usual therapeutic doses of morphine sulfate may increase airway resistance and decrease respiratory drive to the point of apnea. Consider alternative non-opioid analgesics and use morphine sulfate only under careful medical supervision, at the lowest effective dose in such clients. Misuse, abuse, and diversion of opioids. Morphine sulfate is an opioid agonist and a Schedule II controlled substance. Such drugs are sought by drug abusers and people with addiction disorders. Diversion of Schedule II products is an act subject to criminal penalty. Morphine can be abused in a manner similar to other opioid agonists, legal or illicit. This should be considered when prescribing or dispensing morphine sulfate in situations where there is increased risk of misuse, abuse, or diversion. Morphine may be abused by crushing, chewing, snorting, or injecting the product. These practices pose a significant risk to the abuser that could result in overdose and death. Interactions with alcohol and drugs of abuse. Morphine has addictive effects when used in conjunction with alcohol, other opioids, or illicit drugs that cause central nervous system depression and respiratory depression, hypotension, profound sedation, coma, or death may result. Use in head injury and increased intracranial pressure. In the presence of head injury, intracranial lesions, or a pre-existing increase in intracranial pressure, the possible respiratory depressant effects of morphine and its potential to elevate cerebrospinal fluid pressure may be markedly exaggerated. Furthermore, morphine can produce effects on pupillary response and consciousness, which may obscure neurologic signs of increased intracranial pressure in clients with head injuries. Hypotensive effect. Morphine may cause severe hypotension in individuals unable to maintain blood pressure who have already been compromised by a depleted blood volume or drug administration of phenothiazines or general anesthetics. Administer morphine sulfate with caution to clients in circulatory shock, as vasodilation produced by the drug may further reduce cardiac output and blood pressure. Gastrointestinal effects. Do not administer morphine to clients with gastrointestinal obstruction, especially paralytic ileus, because morphine diminishes propulsive peristaltic waves in the gastrointestinal tract and may prolong the obstruction. The administration of morphine sulfate may obscure the diagnosis or clinical course in clients with an acute abdominal condition. Use in pancreatic biliary tract disease. Use morphine with caution in clients with biliary tract disease, including acute pancreatitis, as morphine. Special risk groups. Use morphine with caution and in reduced dosages in clients with severe renal or hepatic impairment, Addison's disease, hypothyroidism, prostatic hypertrophy, urethral stricture, and in elderly or debilitated clients. Exercise caution in the administration of morphine sulfate to clients with CNS depression, toxic psychosis, acute alcoholism, and delirium tremens. All opioids may aggravate convulsions in clients with convulsive disorders, and all opioids may induce or aggravate seizures. Driving and operating machinery. Caution clients that morphine sulfate could impair the mental and/or physical abilities needed to perform potentially hazardous activities, such as driving a car or operating machinery. Caution clients about the potential combined effects of morphine sulfate with other CNS depressants, including other opioids, phenothiazines, sedative hypnotics, and alcohol. Now let's take a closer look at the medication grid on morphine, in Table 11, 12, 13, 10.7a, Table 10.7a Morphine Medication Grid. 11. Franzen G. and Pennington S. Ames's clinical drug, rationales for nursing practice. 305, 310, 952 to 953, 959 to 960. Walters Kluwer. 13. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. Oral morphine was administered to a client for rib pain from metastatic lung cancer. When should the effectiveness of the medication be evaluated? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Naloxone. Mechanism of action. Naloxone reverses analgesia and the CNS and respiratory depression caused by opioid agonists. It competes with opioid receptor sites in the brain and thereby prevents binding with receptors or displaces opioids already occupying receptor sites. Indications: naloxone is indicated for the complete or partial reversal of opioid depression, including respiratory depression induced by natural and synthetic opioids. Nursing considerations: naloxone is safe for all ages. Side effects: adverse effects. Adverse effects include tremors, drowsiness, sweating, decreased respirations, hypertension, nausea, and vomiting. Health teaching and health promotion. Clients should be advised regarding the risks associated with opioid analgesic use and the need for opioid antagonists. Please see the outlined special considerations for usage 14 below. Special considerations. Postoperative. The following adverse events have been associated with the use of naloxone hydrochloride injection in postoperative clients: hypotension, hypertension, ventricular tachycardia and fibrillation, dyspnea, pulmonary edema and cardiac arrest, death, coma, and encephalopathy have been reported as results of these events. Excessive doses of naloxone in postoperative clients may result in significant reversal of analgesia and may cause agitation. Opioid depression. Abrupt reversal of opioid depression may result in nausea, vomiting, sweating, tachycardia, increased blood pressure, tremulousness, seizures, ventricular tachycardia and fibrillation, pulmonary edema, and cardiac arrest, which may result in death. Opioid dependence. Abrupt reversal of opioid effects in persons who are physically dependent on opioids may precipitate an acute withdrawal syndrome, which may include, but not limited to, the following signs and symptoms: body aches, fever, sweating, runny nose, sneezing, pilorection, yawning, weakness, shivering or trembling, nervousness, restlessness or irritability, diarrhea, nausea or vomiting, abdominal cramps, increased blood pressure, and tachycardia. In the neonate, opioid withdrawal may also include convulsions, excessive crying, and hyperactive reflexes. Now let's take a closer look at the medication grid on naloxone, in Table 1516, 10.7 billions. Table 10.7 billions, naloxone medication grid. A postoperative client just received naloxone for respiratory depression. When should the client's respiratory status be reassessed? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. 10.8 Adjuvant analgesics. Adjuvant analgesics are medications that were developed for other purposes but were later found to be effective to treat pain. Examples of adjuvant medications include gabapentin and amitriptyline. Additional information about these specific adjuvant medications can be found in the central nervous system chapter. Muscle relaxants are also considered an adjuvant analgesic and are used for various musculoskeletal disorders such as multiple sclerosis. 3 different types of muscle relaxants will be discussed below: baclofen, cyclobenzaprine, and tizanidine. Baclofen. Mechanism of action: baclofen inhibits reflexes at the spinal level. Indications: baclofen is used to treat muscle symptoms, such as spasm, pain, and stiffness, caused by multiple sclerosis, spinal cord injuries, or other spinal cord disorders. Nursing considerations: baclofen is safe for clients 12 years and older. Side effects: adverse effects. Adverse effects include drowsiness, dizziness or lightheadedness, confusion, nausea, constipation, and muscle weakness. Abrupt drug withdrawal. Hallucinations and seizures have occurred on abrupt withdrawal of baclofen. Therefore, except for serious adverse reactions, the dose should be reduced slowly when the drug is discontinued. Impaired renal function. Because baclofen is primarily excreted unchanged through the kidneys, it should be given with caution, and it may be necessary to reduce the dosage. Signs and symptoms of overdose include vomiting, muscular hypotonia, drowsiness, accommodation disorders of the eye, coma, respiratory depression, and seizures. Health teaching and health promotion. The medication should be taken as directed and abrupt withdrawal of the medication should be avoided. It may cause dizziness or drowsiness. Clients should be advised to change positions slowly because of the potential orthostatic changes that may occur. Additionally, clients should avoid concurrent use with alcohol or other CNS-1 depressants. Now let's take a closer look at the medication grid on baclofen in Table 2 310.08a. Table 10.8a Baclofen Medication Grid. 1. Use central from Unbound Medicine. 3. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. A client just started taking baclofen for muscle spasticity due to multiple sclerosis. What teaching should the nurse provide? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Cyclobenzaprine. Mechanism of action. Cyclobenzaprine reduces tonic somatic muscle activity at the level of the brainstem. It is structurally similar to tricyclic antidepressants. Nursing considerations. Cyclobenzaprine is safe for clients 15 years and older. Use cautiously with elderly clients, clients with hepatic impairment, and those who take antidepressants and other CNS depressants. In the elderly, the frequency and severity of adverse events associated with the use of cyclobenzaprine, with or without concomitant medications, are increased. In elderly clients, cyclobenzaprine should be initiated with a 5 mg dose and titrated slowly upward. Side effects, adverse effects. Adverse effects include dizziness, drowsiness, dry mouth, urinary retention, serotonin syndrome with antidepressant use, or increased sedation with other CNS depressants. Serotonin syndrome. The development of a potentially life-threatening serotonin syndrome has been reported with cyclobenzaprine hydrochloride when used in combination with other drugs, such as selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, tricyclic antidepressants, tramadol, bupropion, meperidine, verapamil, or MAO inhibitors. The concomitant use of cyclobenzaprine hydrochloride with MAO inhibitors is contraindicated. Serotonin syndrome symptoms may include mental status changes, autonomic instability, neuromuscular abnormalities, and/or gastrointestinal symptoms. Treatment with cyclobenzaprine hydrochloride and any concomitant serotonergic agents should be discontinued immediately if the above reactions occur, and supportive symptomatic treatment should be initiated. If concomitant treatment with cyclobenzaprine hydrochloride and other serotonergic drugs is clinically warranted, careful observation is advised, particularly during treatment initiation or dose increases. General, because of its atropine-like action, cyclobenzaprine hydrochloride should be used with caution in clients with a history of urinary retention, angle closure glaucoma, increased intraocular pressure, and in those taking anticholinergic medication, impaired hepatic function. The plasma concentration of cyclobenzaprine is increased in clients with hepatic impairment. Cyclobenzaprine, especially when used with alcohol or other CNS depressants, may impair mental and/or physical abilities required for performance of hazardous tasks, such as operating machinery or driving a motor vehicle. Health teaching and health promotion. The medication should be taken as directed. It may cause dizziness or drowsiness. Clients should be advised to change positions slowly because of the potential orthostatic changes that may occur. Additionally, clients should avoid concurrent use with alcohol or other CNS depressants. Clients should be aware that constipation may occur as a side effect of medication therapy, and increased fluid intake may assist in preventing complications. Now let's take a closer look at the medication grid on cyclobenzaprine in 5.6 Table 10.8b. Table 10.8b, cyclobenzaprine medication grid. A client asks if they can drive their car while taking cyclobenzaprine. What is the nurse's best response? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. Tizanidine. Mechanism of action. Tizanidine acts as an agonist at central alpha-adrenergic receptor sites. It reduces spasticity by increasing presynaptic inhibition of motor neurons. Indications: tizanidine is used to treat increased muscle tone, spasms, and spasticity. Nursing considerations: tizanidine is safe for adults. Dosage adjustment may be required for the geriatric population. Side effects: adverse effects. Adverse effects include somnolence, dry mouth, hypotension, bradycardia, dizziness, fatigue, weakness or asthenia, hallucinations, liver function test abnormality, and hepatotoxicity. Health teaching and health promotion. The medication should be taken as directed. It may cause dizziness or drowsiness. Clients should be advised to change positions slowly because of the potential orthostatic changes that may occur. Additionally, clients should avoid concurrent use with alcohol or 7 other CNS depressants. Now let's take a closer look at the medication grid on tizanidine in Table 8, 9, 10, 10.8c. Table 10.8c, tizanidine medication grid. 7. U Central from Unbound Medicine. 8. France N.G. and Pennington S. Abrams Clinical Drug Rationales for Nursing Practice. pp. 305, 310, 952 to 953, 959 to 960. Walters Kluwer, 9, Valorand A. and Sanofsky C.A. Davis's Drug Guide for Nurses. F. A. Davis Company. 10. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. Critical Thinking Activity 10.8c. A client asks, why should I not drink alcohol with tizanidine? What is the nurse's best response? Note: answers to the critical thinking activities can be found in the answer key section at the end of the book. 10.09 Anti-gout medications. Anti-gout medications are used to treat gout, a musculoskeletal disorder. Allopurinol is commonly used to prevent gout from recurring. Colchicine, classified as anti-inflammatory medication, is used to prevent and treat acute gout flares. Allopurinol. Mechanism of action. Allopurinol blocks the production of uric acid by inhibiting the action of xanthine oxidase. Indications: allopurinol is used for the prevention of gouty arthritis and for the treatment of secondary hyperuricemia. Nursing considerations: allopurinol is safe for all ages. For clients with renal impairment, the dose will be reduced. Side effects: adverse effects. Adverse effects include hypotension, flushing, drowsiness, nausea and vomiting, diarrhea, hepatitis, renal failure, drug rash with eosinophilia and systemic symptom syndrome, or drug 1 hypersensitivity syndrome. Health teaching and health promotion. The medication should be taken as directed. An alkaline diet may be ordered for the client, and they may be advised to increase fluid intake to prevent kidney stone formation. The medication may cause dizziness or drowsiness. Clients who consume large amounts of alcohol may increase uric acid concentrations and decrease the effectiveness of the medication. If a client develops a rash or blood in the urine, these new symptoms should be reported promptly to the healthcare provider. Colchicine. Mechanism of action: colchicine has primarily anti-inflammatory properties. Indications: colchicine is indicated for prophylaxis and the treatment of acute gout flares. Nursing considerations: the recommended dosage of colchicine depends on the client's age, renal function, hepatic function, and use of co-administered drugs. Colchicine is not an analgesic medication and should not be used to treat pain from other causes. It is administered orally without regard to meals. Side effects: adverse effects. The most commonly reported side effect of colchicine is diarrhea. Life-threatening and fatal drug interactions have been reported in clients treated with colchicine given with PGP and strong CYP3A4 inhibitors. Myelosuppression, leukopenia, granulocytopenia, thrombocytopenia, pancytopenia, and aplastic anemia have been reported with colchicine used in therapeutic doses. Colchicine-induced neuromuscular toxicity and rhabdomyolysis have been reported in elderly clients and those with renal dysfunction. Health teaching and health promotion: clients should be instructed to take colchicine as prescribed, even if they are feeling better. Clients should not alter the dose or discontinue treatment without consulting with their provider. They should report to their healthcare provider all of the current medications they are taking and check before starting any new medications, particularly antibiotics, as well as non-prescription medication or herbal products. Grapefruit and grapefruit juice may also interact and should not be consumed during colchicine treatment. Clients should be informed to seek medication evaluation immediately if muscle pain or weakness, tingling, or numbness in fingers or toes occur. Now let's take a closer look at the medication grid on anti-gout medication 3 in Table 1009. Table 1009 Anti-gout medication grid. 10.10 Antimigraine medications. Migraines are a neurological disorder characterized by severe and recurring headaches and other symptoms such as sensitivity to light, sound, and smells, and nausea. The treatment of migraines includes both acute and preventative medications. The following is a list of some common medications used to treat migraines. Triptans. Mechanism of action: triptans bind to serotonin receptors, specifically the 5-HT1B and 5-HT1D receptors. Activation of these receptors leads to vasoconstriction of the dilated blood vessels in the brain, which is thought to be one of the key factors involved in migraines. Indication: triptans inhibit the release of pro-inflammatory neuropeptides, such as substance P and calcitonin gene-related peptide, which are involved in the pain and inflammation associated with migraines. In addition, they may also reduce the sensitivity of the trigeminal nerve, which is a major source of pain in migraines, subcutaneously or as a nasal spray. The medication should be administered at the onset of the migraine and may be repeated once after 2 hours but not to exceed 200 mg per day. Side effects: adverse effects. Adverse effects of triptans include dizziness, vertigo, somnolence, nausea, vomiting, chest discomfort, and angina. Health teaching and health promotion: advise the client to take the medication as soon as possible after the onset of the migraine symptoms. Additionally, it is important to acknowledge lifestyle changes that may be of benefit to help prevent migraine attacks, such as stress management techniques, exercise, and avoidance of triggers. Now let's take a closer look at sumatriptan in the medication grid Table 10.10a. Table 10.10a Sumatriptan grid. Ergot alkaloids. Mechanism of action: ergot alkaloids work by narrowing the blood vessels within the brain. Indication: ergot alkaloids are used for the acute treatment of migraines. Nursing considerations: ergot alkaloid medications may be administered orally, rectally, sublingually, or as a nasal spray. Side effects: adverse effects. Side effects may include nausea, vomiting, and abdominal pain. Health teaching and health promotion: medication should be taken exactly as prescribed by the healthcare provider. Do not exceed the prescribed dose or take the medication for longer than prescribed. Clients should avoid the use of alcohol while taking the medications. Abrupt cessation of medication may elicit withdrawal symptoms such as headache, nausea, vomiting, and muscle pain. Now let's take a closer look at ergotamine in the medication grid Table 10.10 billions. Table 10.10 billions Ergotamine. 10.11 Anesthetics. As a nurse, you may care for clients prior to surgery, during surgery, or after surgery. One of your roles is to monitor the effects of anesthetics on your client's vital signs, paying close attention to respiratory status, as well as their level of consciousness and pain level. There are three categories of anesthetics. Local anesthetic is when a medication is injected into the skin at the site of the procedure to achieve numbness for procedures like suturing. EMLA cream is a combination of lidocaine and prilocaine, used before procedures such as starting intravenous access, especially for children. Read more information about lidocaine and EMLA cream in Table 10.1.1. Conscious sedation. Conscious sedation is a combination of medications that allow the client to be relaxed and free of pain during a medical procedure. This allows the client to remain awake and aware, without feeling discomfort. The client may or may not be able to speak or respond in this state. General anesthesia. General anesthesia is a medication-induced reversible unconsciousness with loss of protective reflexes. Arousal, even to painful stimuli, cannot occur. General anesthesia requires the establishment and maintenance of airway control. Propofol is an example of an intravenous general anesthetic. The intravenous injection of propofol induces anesthesia within 40 seconds from the start of 2 injection. Table 10.1. 1. Local anesthetics. 1. Franson G. and Pennington S. M's Clinical Drug Rationales for Nursing Practice. pp. 305, 310, 952 to 953, 959 to 960. Walters Kluwer. 2. This work is a derivative of Daily Med by U.S. National Library of Medicine in the public domain. 10.1. 2 Learning activities. Lightbulb moment. Now let's apply what you have learned. Your 82-year-old postoperative client is hard to arouse 30 minutes after you administered IV morphine. Their BP is 102/70 seconds, respirations are 8 and shallow, and SpO2 is 88% on room air. Which of the following are priority nursing actions? Select all that apply. 1. Administer oxygen. 2. Administer naloxone. 3. Insert a Foley catheter. 4. Increase IV fluid rate. 5. Raise the head of the bed. Note: answers to the lightbulb moment can be found in the answer key section at the end of the book. Case Study 1. Mrs. Penja is a 65-year-old female who has been admitted to the hospital for a left hip fracture. She has a history of hypertension and osteoarthritis. Mrs. Penja reports severe pain in her left hip, which is affecting her ability to move and sleep. She is currently being treated with acetaminophen and ibuprofen, but the pain persists. The healthcare provider prescribes Toradol as an additional analgesic. 1. What is Toradol, and how does it work? 2. What are the side effects of Toradol? How should Toradol be administered? 3. 4. What precautions should be taken when using Toradol? Long should Toradol be used for pain? 6. What alternative analgesics could be used instead of Toradol? Case Study 2. Mr. Johnson is a 40-year-old male who has been brought to the emergency department by ambulance. He was found unresponsive in his home with shallow breathing and pinpoint pupils. He has a history of opioid addiction and has recently relapsed. The healthcare provider suspects an opioid overdose and orders Narcan. What is Narcan and how does it work? 2. How should Narcan be administered? 3. What are the potential side effects of Narcan? 4. What precautions should be taken when using Narcan? 5. What is the expected outcome after administering Narcan in an opioid overdose? Note: answers to the case studies can be found in the answer key section at the end of the book. An interactive H5P element has been excluded from this version of the text. You can view it online here. Analgesic flashcards by E. Chrisman for OpenRN is licensed under CC BY. An interactive H5P element has been excluded from this version of the text. You can view it online here. Analgesic medication matching activity by E. Chrisman for OpenRN is licensed under CC BY 4. An interactive HSP element has been excluded from this version of the text. You can view it online here. Analgesic quiz by E. Chrisman for OpenRN is licensed under CC BY 4. Test your clinical judgment with this. NCLEX Next Generation Style Bowtie Question. Analgesics and 1 Musculoskeletal Assignment 1. Test your clinical judgment with this NCLEX Next Generation Style Bowtie 2 question. Analgesics and musculoskeletal assignment. 2. 10th glossary. Acute pain, pain that usually starts suddenly and has a known cause, like an injury or surgery. It normally gets better as your body heals and lasts less than 3 months. Adjuvant analgesics. Drugs with a primary indication other than pain that have analgesic properties in some painful conditions. The group includes numerous drugs in diverse classes such as gabapentin or amitriptyline. Chronic pain. Pain that lasts 6 months or more and can be caused by a disease or condition, injury, medical treatment, inflammation, or an unknown reason. Immune-mediated disease process occurs when the body's immune system attacks the central nervous system. Misuse, the use of illegal drugs and/or the use of prescription drugs in a manner other than as directed by a provider, such as using in greater amounts, more often or longer than told to take a drug, or using someone else's prescription. Muscle spasticity, condition in which certain muscles are continuously contracted. This contraction causes stiffness or tightness of the muscles, and can interfere with normal movement, speech, and gait. Spasticity is usually caused by damage to the portion of the brain or spinal cord that controls voluntary movement. Nociceptors, nerve endings that selectively respond to painful stimuli and send pain signals to the brain and spinal cord. Non-pharmacologic therapy, treatments that do not involve medications, including physical treatments and cognitive behavioral treatments. Patient-controlled analgesia. To receive the opioid, the patient pushes a button on the PCA device, which releases a specific dose but also has a lockout mechanism to prevent an overdose, included with hydromorphone or fentanyl. Prostaglandins, produced in nearly all cells and are part of the body's way of dealing with injury and illness. Prostaglandins act as signals to control several different processes depending on the part of the body in which they are made. Prostaglandins are made at the sites of tissue damage or infection, where they cause inflammation, pain, and fever as part of the healing process. Vertigo, a sense of spinning dizziness. It is a symptom of a range of conditions. It can happen when there is a problem with the inner ear, brain, or sensory nerve pathway. Part 11. Answer key. Answer keys for the critical thinking activities and light bulb moments in each chapter are provided in the following sections. 10. Chapter 10. Answer key to Chapter 10. You can review additional information regarding these answers in the corresponding section in which the critical thinking activities appear. Critical thinking activity section 10.6a. The client should be advised that acetaminophen can cause acute liver damage when taken in excessive amounts or when used with alcohol. Many over-the-counter medications contain acetaminophen, so daily amounts must be monitored carefully. Recommended daily restrictions for acetaminophen include less than 4,000 milligrams of acetaminophen in 24 hours for an adult, less than 3,200 milligrams for geriatric adults, and less than 2,000 milligrams for clients with alcoholism. Fewer than 3 alcoholic drinks should be consumed daily while using acetaminophen. Critical thinking activity section 10.6 billions. The client should be advised that aspirin has an antiplatelet effect, in addition to reducing pain, fever, and inflammation. By preventing the platelets from sticking together, clots that can cause heart attacks and strokes are prevented from forming. Critical thinking activity section 10.6c. Ibuprofen is a non-steroidal anti-inflammatory drug, which can cause severe and life-threatening stomach bleeding and must be taken cautiously. The client should be advised that the risk for bleeding is higher if the client is age 60 or older, has had stomach ulcers or bleeding problems, takes an anticoagulant or steroid medication, takes other drugs containing NSAIDs such as aspirin, ibuprofen, or naproxen, consumes 3 or more alcoholic drinks every day while using this product, takes ibuprofen in higher doses, more frequently, or for a longer time than directed. Critical thinking activity section 10.6d. The nurse should evaluate the effectiveness of ketorolac in relieving the client's pain 30 minutes after administration. Critical thinking activity section 10.6e. The nurse should provide the following health teaching regarding celecoxib. It may be taken with or without food. You can sprinkle capsules on applesauce and ingest it immediately with water. You may experience heartburn, vomiting, or diarrhea with this medication. Notify the provider immediately if you have abdominal pain, vomit blood, or have blood in your stool, develop swelling in your hand or feet, or notice yellowing of your skin. Critical Thinking Activity Section 10.7a. Oral drops of morphine, commonly used for clients with metastatic cancer, should be effective within 1 hour of administration. Critical Thinking Activity Section 10.7 Billions. Naloxone immediately reverses the effects of respiratory depression and oversedations caused by opioids. After a client receives naloxone, the nurse should continue to evaluate the client's respiratory status at least every 15 minutes. Because naloxone has a shorter duration of action than many opioids, and repeated doses are usually necessary. Critical Thinking Activity Section 10.8a. The nurse should educate the client to take baclofen with milk or food to minimize gastric upset. Advise the client that baclofen may cause dizziness or drowsiness, so they should change positions slowly and avoid driving and operating machines. Clients using baclofen should avoid using alcohol or taking other CNS depressants. Critical Thinking Activity Section 10.8 Billions. Cyclobenzaprine is a muscle relaxer and may cause drowsiness. If used with alcohol or other CNS depressants, it can impair mental or physical abilities, so the client should be advised to not drive when taking cyclobenzaprine. Critical Thinking Activity Section 10.8c. The client should be advised that tizanidine can cause drowsiness and dizziness, and concurrent use with alcohol can worsen these effects. Tizanidine can damage the liver, so alcohol should be avoided to prevent additional damage. Section 10.01-2 Lightbulb Moment. The correct answers are A, B, and E. Based on the client's respiratory status, the nurse should immediately raise the client's bed and apply oxygen to rapidly increase their oxygenation level. The nurse should ask for help from a team member and/or call the rapid response team while obtaining naloxone to administer for sedation and respiratory depression. The nurse should continue to monitor the client's respiratory status after naloxone is administered because repeated doses may be required. Section 10.12 Case Study 1. Toradol is a non-steroidal anti-inflammatory drug that works by blocking the production of prostaglandins, which are chemicals that cause pain, inflammation, and fever. It is used to treat moderate to severe pain, such as postoperative pain or pain associated with musculoskeletal injuries. 2. The side effects of Toradol can include nausea, vomiting, constipation, diarrhea, dizziness, headache, drowsiness, and stomach pain. More serious side effects can include stomach ulcers, bleeding, and kidney problems. It can also increase the risk of heart attack and stroke, especially with long-term use or in clients with pre-existing cardiovascular disease. 3. Toradol can be administered orally, intramuscularly, or intravenously. The recommended dose for oral and intramuscular administration is 10 mg every 4 to 6 hours, not to exceed 40 mg per day. For intravenous administration, the recommended dose is 30 mg as a single dose or 15 mg every 6 hours, not to exceed 60 mg per day. 4. Toradol should be used with caution in clients with a history of gastrointestinal bleeding or ulcers, kidney disease, heart disease, or bleeding disorders. It should not be used in clients who are allergic to NSAIDs or aspirin, or who have a history of asthma, hives, or other allergic reactions to these drugs. It should also be avoided in pregnant women and nursing mothers. 5. Toradol should be used for the shortest duration possible, typically no more than 5 days, due to the risk of serious side effects with prolonged use. It should not be used for chronic pain management. 6. Alternative analgesics that could be used instead of Toradol include acetaminophen, opioids, and other NSAIDs such as ibuprofen or naproxen. The choice of analgesic should be based on the client's individual needs and medical history. Section 10.12 Case Study 2. 1. Narcan is an opioid antagonist that works by blocking the effects of opioids on the central nervous system. It quickly reverses the effects of an opioid overdose, including respiratory depression and sedation. 2. Narcan can be administered intravenously, intramuscularly, subcutaneously, or intranasally. The route of administration will depend on the client's condition and the available equipment. The dose of Narcan will also depend on the client's weight and the severity of the overdose. 3. The potential side effects of Narcan can include nausea, vomiting, sweating, tremors, anxiety, and irritability. In some cases, Narcan can cause rapid and severe withdrawal symptoms. which can include seizures, hypertension, tachycardia, and pulmonary edema. 4. When using Narcan, healthcare providers should take precautions to ensure that the client's airway is protected and that they receive adequate oxygenation and ventilation. Narcan should be used with caution in clients with a history of cardiac disease, hypertension, or seizures. It should also be used with caution in clients who are pregnant or nursing. 5. The expected outcome after administering Narcan in an opioid overdose is rapid reversal of respiratory depression and sedation. The client should be monitored closely for signs of withdrawal and respiratory depression, as additional doses of Narcan may be necessary. The healthcare provider should also address the underlying opioid addiction and provide appropriate treatment and resources to prevent future overdose. Appendix A. Additional information related to the NCLEX test plan. The 2023 NCLEX-PN and NCLEX-RN test plans contain a client need category entitled Pharmacological and Enteral Therapies to assist students in preparing for the NCLEX based on the activity statements provided for this category. In addition to the content contained in this book, links to related content in the series of Open RN OER textbooks are provided below. Administer blood products and evaluate client response. Administer blood products chapter in Open RN Advanced Skills. Access and/or maintain central venous access devices. Manage central lines chapter in Open RN Advanced Skills. Perform calculations need for medication administration. Math calculations chapter in Open RN Nursing Skills. Prepare and administer medications using the rights of medication administration. Administration of enteral medications chapter in Open RN Nursing Skills. Monitor intravenous infusion and maintain site, IV therapy management chapter in Open RN Nursing Skills. Administer parenteral nutrition and evaluate client response, applying the nursing process section in the nutrition chapter of Open RN Nursing Fundamentals.